Welcome, CyberMDs, to another cardiology lecture for the USMLE Step 1 exam. Today's lecture will cover myocardial ischemia and infarction. Before we get started, please remember to like, comment, and/or subscribe if you find the content here useful in any way so that we can continue to provide free medical education resources for students around the world. Additionally, please tell your friends about our content and let us know if you think that we can improve the lectures in any way at all. For this lecture, we'll discuss the various pathologies and we'll also correlate them with clinical applications of the material that is necessary to know for Step 1. Now, let's dive into the lecture. First, let's talk about myocardial ischemia from a macro standpoint. Ischemic heart disease is actually the #1 cause of death in the United States. Additionally, it has similar risk factors to atherosclerosis, as atherosclerosis of the coronary vessels is the leading cause of ischemic heart disease. Similar to atherosclerosis, this is a disease that is more common as people age. For the purposes of this lecture, it is really important to remember that ischemia, which again is merely reduced blood flow leading to an inability to meet the oxygen and nutrient demands of a tissue, in this case the myocardium, this can come from a variety of etiologies. Because it comes from a variety of etiologies, ischemic heart disease is actually a group of pathologic processes that all lead to myocardial ischemia. However, in the end, it is simply a mismatch between myocardial energy demands and coronary blood supply, no matter the underlying etiology. The most common etiologies include atherosclerosis, vasospasm, inflammation, and microvascular dysfunction. Clinically, all of these can lead to a patient presenting with angina, which is a fancy term for chest pain. In atherosclerotic ischemia, also known as coronary artery disease, there is an atherosclerotic plaque that causes a reduction in blood flow to the cardiac myocytes. In vasospastic ischemia, constriction of the coronary arteries leads to ischemia distal to the site of the vasospasm. Several different factors can cause this, such as atherosclerosis, cocaine or marijuana use, exercise, cold exposure, as well as some medications such as sumatriptan and ephedrine. With regards to inflammatory ischemia, this refers to local inflammation within the heart that makes a pre-existing atherosclerotic process more prone to rupture and subsequent thrombosis and occlusion. The inflammatory process causes leukocytes to bind to the endothelium, which could enhance the inflammatory response. And remember that inflammatory responses can produce proteolytic enzymes that, again, may cause an atherosclerotic plaque to rupture with potential subsequent thrombosis and occlusion of that vessel. Finally, with regards to microvascular dysfunction, it should be noted that the entirety of the pathophysiology and microvascular dysfunction and ischemic heart disease has not yet been fully worked out. With that being said, it is worth noting that this is a non-obstructive disease, which makes it different from the other sources of ischemia that we've been discussing so far. This particular etiology is thought to be due to vascular smooth muscle dysfunction, meaning the coronary vasculature cannot dilate to accommodate a need for increased blood flow. A vasoconstrictive response to various stimuli, such as stress, is another particular etiology for this. And then a potential etiology is also capillary dysfunction. I want to be very clear that this is currently not high yield for Step 1, but I felt like it was still worth mentioning. For the rest of this lecture, we are going to focus on atherosclerosis and vasospasm, and we will do so through the paradigm of angina, aka chest pain, as this is classically the complaint that patients will show up to the emergency department or the outpatient clinic with. Angina, which again is the presenting complaint for these patients, is classically categorized as stable, unstable, or vasospastic. Vasospastic can also be called Prinzmetal angina. Each of these are classically associated with specific EKG findings as well as other clinical characteristics. In addition to these classifications, there are other clinical definitions defined by EKG findings that you should be aware of and that we will cover. Remember that no matter which of these we are discussing, we are still talking about a situation in which the heart's energy and oxygen demands are not being met. Therefore, it's important to remember some of the things that often increase the energy and oxygen demands of the heart. These are the 4 E's of angina: exercise, emotional stress, exposure to cold, and eating. Keeping that in mind, let's talk about vasospastic angina, which is the outlier of this spectrum of pathologies. So, vasospastic angina, which is also, again, known as Prinzmetal angina or variant angina, is a rather unique form of angina that is characterized by transient or intermittent episodes of chest pain that are caused by coronary artery vasospasm. This particular type of angina is classically attributed to the aberrant smooth muscle contraction of coronary arteries, which is occurring independent of the presence of significant atherosclerotic lesions. So, while these patients may have atherosclerotic lesions, the presence of those lesions is not necessary for the presence of Prinzmetal angina. The ischemia that this causes is typically reversible. However, the ischemia may be subendocardial or transmural, meaning that it may or may not extend the entire thickness of the myocardium. It is typically subendocardial. This is important when it comes to clinical presentation and testing. It is worth noting that this can cause both NSTEMI or STEMI, 2 classifications that we will discuss later, but that this would be atypical. The exact prevalence of vasospastic angina is not well defined. It affects both men and women and often affects individuals in their 40s. Patients with underlying risk factors, such as smoking and hypertension, are at higher risk. Vasospastic angina is associated with conditions such as migraine, Raynaud's phenomenon, and peripheral artery disease. This makes sense as the etiology or etiologies of these diseases can be from vasospasm as well. So in a patient with vasospasm in the periphery, it makes sense that it may also occur in the vasculature of the heart. Patients with vasospastic angina experience episodes of chest pain at rest or during exertion, and they often occur during the early morning hours. The pain can be severe, squeezing, and may radiate to the left arm or to the jaw or to the shoulder. Episodes commonly occur during periods of rest or sleep or exposure to cold temperatures. Risk factors for vasospastic angina include endothelial dysfunction, increased sympathetic tone, and hyperreactivity of smooth muscle cells. Other factors, such as smoking, cocaine use, and exposure to cold temperatures, may trigger vasospasm. Diagnosing vasospastic angina requires a comprehensive evaluation. During an episode, the EKG may show transient ST segment elevation. However, EKG findings can be normal during pain-free periods. Provocative testing using agents like ergonovine or acetylcholine during coronary angiography can induce and reproduce coronary artery spasm, confirming the diagnosis. Untreated or recurrent episodes of vasospastic angina can lead to myocardial infarction as well as life-threatening arrhythmias and sudden cardiac death. The management of vasospastic angina aims to relieve symptoms, prevent recurrent episodes, and reduce the risk of complications. Vasodilators, particularly nitrates like sublingual nitroglycerin, provide acute relief and prophylaxis. Calcium channel blockers such as verapamil and diltiazem are commonly used as long-term therapy. Lifestyle modifications, including smoking cessation, avoidance of cold exposure, and stress reduction, are also important in managing vasospastic angina. Next, we will be discussing angina and infarction, which I think is best thought of as a spectrum of disease. Because this is a spectrum, the epidemiology, etiology, and risk factors are essentially all the same. These diagnoses increase with age and typically affect men more often than they affect women. Risk factors include smoking, hypertension, diabetes, hyperlipidemia, family history of coronary artery disease, a sedentary lifestyle, and again, male gender. So again, this is a spectrum of disease, and it is organized on this slide as it progresses in severity from left to right. With each progression on the slide, the things that are bolded are things that are different from the previous diagnosis. Let's start on the left with stable angina. Stable angina is chest pain or discomfort that arises with physical exertion or emotional stress and is relieved by rest or nitroglycerin. Of course, it is caused by atherosclerosis of the coronary arteries, which results in a reduced blood flow to the myocardium downstream from the atherosclerotic plaque. This prevents the oxygen demands of the downstream tissue from being met. Subsequently, cellular injury ensues. However, the injury that this causes to the cardiac myocytes is a reversible injury. Think about nitroglycerin or rest restoring the blood flow and restoring normal cellular function to the myocytes. The ischemia that this causes is subendocardial. This means that the ischemia caused by stable angina does not traverse the entire thickness of the myocardium. This is important to remember as subendocardial ischemia causes ST segment depressions. Classically, the stenosis or occlusion is approximately 70% or more of a coronary vessel at a given point. Typically, the chest pain in these patients lasts less than 10 or 20 minutes. Lack of treatment of this condition can lead to a progression to one of the acute coronary syndrome pathologies, which are the other pathologies listed on this slide. The diagnosis of stable angina involves a thorough medical history and physical exam, as well as the appropriate diagnostic tests. EKG may show transient ST segment depression during angina episodes. Exercise stress testing, stress echocardiography, or nuclear imaging can be performed to provoke angina and assess myocardial perfusion and wall motion abnormalities. All of these help to determine the severity of the patient's atherosclerotic occlusion. The management of stable angina focuses on reducing symptoms, preventing complications, and improving overall quality of life for the patient. Lifestyle modifications include smoking cessation, dietary changes, regular exercise, weight management. These are all things that are crucial. Pharmacologic therapy involves antiplatelet agents, beta blockers, and nitroglycerin. Revascularization procedures such as percutaneous coronary intervention, also known as PCI, or coronary artery bypass grafting, also called CABG, may be considered in cases of refractory symptoms or high-risk features. Next, we will discuss unstable angina. This is a manifestation of myocardial ischemia caused by a disrupted atherosclerotic plaque with subsequent thrombosis. This thrombosis is incomplete, so there is still some blood flow distal to the site of the thrombosis. To tie this together, in stable angina, we had a stable plaque that became unstable and ruptured, leading to some thrombosis, and now we have unstable angina. It is characterized by chest pain that occurs at rest, distinguishing it from stable angina. Stable angina does not occur at rest. The damage to myocytes in unstable angina is also reversible, as nitroglycerin can help the tissue that is downstream meet their oxygen demands. This means that the ischemia is subendocardial, not transmural, and there will be ST depressions on the EKG. Unstable angina carries a higher risk of progressing to myocardial infarction, which can result in irreversible myocardial cell death. This should make sense intuitively with the naming system as we have progressed from stable to unstable. It's important to note that in unstable angina, cardiac biomarkers such as troponin should still be within normal limits or negative. The management of unstable angina focuses on relieving symptoms and preventing complications. Initial treatment includes sublingual nitroglycerin for chest pain relief and oxygen supplementation to maintain adequate oxygenation. Antiplatelet therapy with aspirin is often initiated immediately, and additional agents such as the P2Y12 inhibitors may be added later on. High-risk patients may benefit from early invasive management, including coronary angiography with possible PCI or CABG, close monitoring and long-term medication management, including the beta blockers and statins and ACE inhibitors. These are all essential things in management long-term of unstable angina. NSTEMI is the next progression in this spectrum of disease. NSTEMI stands for non-ST segment elevation myocardial infarction. Remember, this is a form of myocardial infarction, meaning there is permanent damage to the myocardium. Essentially, this is very similar and often confused with unstable angina. However, the thrombosis that occurs after the plaque rupture is a little bit more severe. This increase in severity causes some infarction. However, there are no ST segment elevations on the EKG. The EKG changes in NSTEMI may be ST segment depressions, but may also be T-wave inversions. Additionally, and making this most distinguishable from unstable angina, the troponins are positive. Troponin is an intracellular protein, so it can only be elevated in the blood if there is permanent damage and subsequent leakage of intracellular contents into the blood. The treatment is much of the same as we have been discussing: nitroglycerin, oxygen, aspirin, antiplatelets, beta blockers, ACE inhibitors, statins, anticoagulation. Angiography and PCI intervention may be used as well here. Alright, now, STEMI, ST segment elevation myocardial infarction. This is the worst of the acute coronary syndromes. This is typically due to rupture of an atherosclerotic plaque with subsequent thrombosis that completely occludes the vasculature, leading to transmural or full wall thickness ischemia and subsequent necrosis of the myocardium downstream from the occlusion. Because the ischemia is transmural, there are ST segment elevations on the EKG. In addition to this, the permanent damage to the myocytes, the infarction, and the necrosis means that troponins will be positive in this condition. Other etiologies to consider include vasospasm, cocaine use, an embolus in a patient with a PFO, although this is pretty rare and unlikely, as well as some vasculitides such as Kawasaki disease. Again, the treatment is much of the same as we have been discussing. However, the first line treatment is PCI, which again stands for percutaneous coronary intervention, in which a catheter is used to insert a stent into the heart. Ideally, this is done within 2 hours of the patient's first medical contact or within 90 minutes of a patient's arrival to an emergency department. If the patient is outside of that window, sometimes they will receive thrombolytics to burst open the thrombus and try and restore blood flow to the myocardium. Again, nitroglycerin, oxygen, aspirin, antiplatelets, all these things we've been talking about. Regardless, the ultimate goal is to restore blood flow to the myocardium as soon as possible. The classic presentation for these diagnoses is a substernal chest pain that the patient may describe as crushing or a weight on the chest. It may radiate to one or both of the arms, as well as to the neck and or to the jaw. Patients may be sweating or diaphoretic. They may be short of breath, also known as dyspneic, and may describe a quote-unquote sense of impending doom. Additionally, they may have a loss of consciousness, vomiting, or other nausea symptoms. These are classic findings. It is certainly worth noting that in elderly patients, diabetic patients, and female patients, the presentation is more likely to be atypical. Diagnosis of a myocardial infarction involves clinical evaluation and EKG findings and cardiac biomarker testing. In the initial phase of the infarction, the ischemia and necrosis may have only progressed a small amount, maybe less than 50% of the myocardial wall thickness even. In this case of catching the infarction very early, the EKG may show ST segment depressions. However, as time goes on and the area of infarction and necrosis continues to grow, the EKG begins to show ST segment elevations due to the subsequent transmural infarction and necrosis that develops. Therefore, you may consider trending your troponin values, which means getting them multiple times throughout the patient's hospital stay. Laboratory tests detect elevated cardiac enzymes in these patients, with troponin being the most sensitive and specific marker for MI. The CK&B levels are useful for detecting reinfarction. It's important to understand why for this. Troponin is an intracellular protein, so if you see it in the blood, it must be leaking out of cells, indicating permanent cellular damage. Now, the reason that troponin is used for detecting the original infarct and CK&B may be used for detecting reinfarction lies in their time to serum peak. Troponin levels stay elevated for greater than 1 week following an infarction, but CK will only stay elevated for a day or two. So, for example, if you have a patient with an MI whose CK levels suddenly spike 4 to 5 days after their original episode, you should be suspicious for a reinfarction, as their troponin levels will still be elevated above baseline while their CK levels should be normal by that time. Complications of MI are closely related to gross and microscopic changes in the myocardium. We will cover these micro and macro changes in detail in the next lecture. Treatment of myocardial infarction involves a comprehensive approach aimed at minimizing ischemia, preventing further thrombosis, and reducing complications. Thankfully, there is a classic mnemonic known as MONA-BASH that helps us to remember the treatments that are often employed when treating patients who are having or who have had a myocardial infarction. So let's go through each of these treatments and discuss how they help. The morphine is given for the patient's pain when they first present with a myocardial infarction, and the supplemental oxygen helps to ensure that during the acute phase, the maximum amount of oxygen is reaching myocardial tissues. Additionally, nitroglycerin also tries to accomplish this goal. However, the administration of nitroglycerin causes an increase in blood flow rather than the concentration of oxygen itself. Other strategies include the administration of aspirin and other antiplatelet medications, as they will help in preventing the progression of the thrombosis. Beta blockers can be used long-term to slow down the heart rate and decrease the oxygen demand from the cardiac myocytes, while ACE inhibitors can be used to decrease cardiac remodeling following an ischemic event, and they will also help to maintain blood pressures in hypertensive patients. Statins can be used to reduce VLDL and LDL levels in the blood, thus preventing further plaque buildup in the coronary arteries. And then you have heparin or other anticoagulants that may be used to prevent venous thrombosis and the subsequent pulmonary embolism and mural thrombosis following a myocardial infarction, because those will be reducing the activity of the coagulation cascade. Additionally, reperfusion of irreversibly damaged cells, reperfusion of irreversibly damaged cells, such as through PCI, which we've discussed, can lead to hypercontraction and reperfusion injuries. And those can be managed through calcium channel blockers sometimes, as well as with anti-inflammatory agents. There are a few high-yield integrations you should be aware of. First and foremost, you should be able to identify what the most likely vessel occluded is based upon the EKG. Occlusion of the LAD would likely show in leads V1 through V4, while occlusion of the left circumflex would likely be shown in V5 and V6. You may also see this present in lead 1. Additionally, the inferior infarctions often show in leads 2, 3, and AVF. It's also important to remember that with an inferior infarction, the heart becomes preload dependent, and nitroglycerin would decrease preload. So nitroglycerin is typically not given in these patients for this reason. Lastly, remember during our discussion about monitoring for reinfarction that you would monitor that using CK&B levels. And remember why this is preferred over the use of troponin levels, again, specifically for reinfarction. Thanks for tuning in, and be sure to check out the related video on the complications of myocardial infarction, which should be coming soon. Please remember to like, comment, and or subscribe so that we can continue to provide free medical education resources to students all around the world. If you find our videos useful at all, please be sure to let a friend know, and remember that you can catch all of our lectures for free on Spotify. See you next time.